Okay. Let's see. All right. That sounding better now?
Yeah.
Okay, good. So we are here talking about the hip. Hip is one of the largest joints in the human body. It is the largest ball and socket joint in the human body. It's very susceptible to wear and tear. Acute trauma is also a possibility, but the femur is the strongest bone in the body, so it does hold up pretty well, and it has a lot of inherent stability. So we don't really technically see like hip dislocations except from very high energy traumas like motor vehicle accidents, that sort of thing. Like I've certainly reduced plenty of hips in the trauma bay, but it's not something that we generally see from like your ski accident or mountain bike accident, although it's a possibility. I don't know if everybody remembers a couple of years ago, Alabama quarterback, now Dolphins quarterback Tua, he had a hip dislocation and actually fractured the back of his acetabulum, which is the socket of the hip. But more common is kind of the accumulative type injury within the hip, whether this is coming from a impingement or just general wear and tear. When we talk about wear and tear, we're frequently talking about cartilage. That's the smooth bearing surface of the joint, and it's featured here in blue on this picture below here. This is has very low coefficient of friction and allows essentially frictionless motion of the joints across the body. It's very important in the hip in particular. Labrum is a fibrocartilaginous structure. And what that means is a little bit of kind of gummy type tissue that forms a little gasket around the joint itself. And the labrum can be a bad actor in a lot of hip type injuries. One thing that we're frequently pretty concerned about when we're seeing somebody who has hip pain that's not resolving after conservative management. So common causes of hip pain. A couple of things that I did not include on this list that are things that we are always ruling out is actually pain that comes from higher up, that's coming from the spine or nerve compression, because the hip and the spine are very integrally related. But specific to the hip, impingement, which is called femoral acetabular impingement or FAI, and can lead to a labral tear, tendonitis or tendon tears, bursitis, arthritis or other forms of cartilage wear, fractures, sacroiliac joint pain is close to the hip. It's not the hip proper, but it's one of the things that we see a lot in clinic here. And within the kind of spectrum of tendonitis and tendon issues is snapping hip syndrome. We'll get into more detail here. So really the most important thing when you're assessing hip pain is history and physical exam. Because if we just went out and got an MRI on every single person, we'd have a lot of incidental findings and we'd be way over treating people. That generally the location of pain is maybe the most important historical factor. Where on the hip is the pain located? Groin pain, lateral sided pain, posterior pain, and what things are making the pain worse. Have you had prior episodes of this pain, or is this new, et cetera, et cetera. Physical exam. A assessment of the range of motion is how I start on every patient, followed by an inspection for tenderness. In many conditions, we'll be able to provoke tenderness with palpation around the hip, and that's generally a pretty solid indicator that the pain's coming from the hip rather than from the spine. And then provocative maneuvers become very important within the hip, that there are certain exam maneuvers that we know are going to reliably reproduce pain with certain conditions. So that's a big confirmatory exam maneuver. And the hip is very complex and they're very interrelated with the spine. So it becomes one thing that we really need to have a very thorough exam again, because it's easy to get mixed up if you just go MRI everybody's hip. X-rays show us quite a bit in the hip, especially if we're assessing for arthritis, and MRI is pretty critical for assessing most hip conditions, unless we're looking at run-of-the-mill arthritis. So pain that is occurring inside the joint, we actually consider inside that ball and socket joint of the hip. This is normally due to impingement or a labral tear, cartilage wear, which is arthritis falls into that catch-all, and possibly a fracture. Outside the joint, tendons and muscles, bursitis outside the joint, which is the bursa is a smooth sac that allows gliding of tendons over a surface. SI joint pain is a different joint, but it is outside the hip joint. So getting into a little more detail, fractures of the hip, pretty rare that you're going to walk into clinic with a hip fracture. There are stress fractures, which we see sometimes in very high-level runners, people with a very low body mass. Essentially, this is a impending fracture of the hip where the bone is weakened and somebody may present with pretty significant hip pain, may have had a recent uptick in their training before a marathon, et cetera. And this is something that we're always very worried about catching, because we don't want anybody to progress to what we see below here, which is either a intertrochanteric fracture, which is a fracture more on the femur side, or a femoral neck fracture, which is more through close to the ball of the femur. These are fixed. These are 100% surgical injuries, even in the very, like the octogenarian who may be bedbound, that hip fractures we always fix because we don't want somebody to be stuck in bed. There's a lot of comorbidity associated with that. But again, very likely you'd be sitting at home with a hip fracture, so I won't spend too much time talking about that. So femoral acetabular impingement is a very common reason for hip pain. And this is a little complex to understand, but essentially what's occurring is some pinching between the bone on the femur and the acetabulum. And that is caused by bony overgrowth, either on the socket side, the acetabulum side, or on the femur side, on the ball side. So on the acetabular side, we call that a pincher lesion here. And then on the femoral side, we call that a cam lesion. They generally do not exist. They're not normally mutually exclusive. There's normally some reactive bone on each side. And what the result of that pinching bone is a tear of the labrum here. So on this MRI, you can see, perhaps you can appreciate this little triangle that has a little bit of white tracking between it. Same here, little triangle with a little tracking white underneath. That labrum has a very important function within the hip. It increases the surface area of the hip and decreases the force that the cartilage sees. It keeps a suction seal around the hip. So it's very important for long-term hip health. Normally when we're assessing somebody for FAI, the impingement syndrome, generally the hallmark of this condition is groin pain, which is reproducible with either flexion or a little rotation of the femur. There may be mechanical symptoms, meaning like clicking, popping, or catching. That is generally thought to occur from that labrum flipping in and out of the joint where it's torn. And it's really, people always want to know, was I born like this? How did this happen? Generally, it's a little combination of the two, that you probably have a predisposition and you have a little bit of a bump on that femoral neck or a little bit of overhang on that cup side. And then with certain sports, like the hockey goalie that was on the front of the presentation, there is a lot of repetitive impingement, and that leads to further overgrowth of that bone, a labral tear, and then you end up in my office. So the treatment for an FAI or labral tear initially is non-operative treatment. That we'll send you off for physical therapy. That working on core strength and gluteal activation is very critical. But there are certain people who are not going to do well after physical therapy. Generally, people with very large bony lesions are may improve somewhat, but may end up back in the office like, yeah, gave it a shot. I'm still having a lot of hip pain. The next step is consideration of a injection into the joint. And the injection in the joint does not solve the mechanical problem, but it may cool down the inflammation enough that you're able to progress with physical therapy and really nip this in the bud without needing to go under the surgeon's knife. But for a fair amount of people with big bony lesions and a big labral tear, this ends up being a arthroscopic issue. And so with arthroscopy, we are repairing that labral tear and taking down all this bony impingement here. If you see this x-ray, you may be able to appreciate how this relative convexity turned into a definite concavity after shaving this hip down. So hip arthroscopy, we can treat a myriad of conditions with arthroscopic treatment, but is a minimally invasive surgery that if you know somebody who's had their hip replaced, that's a standard open surgery. Hip arthroscopy, we do with several small incisions around the hip, and using those small incisions are able to access the inside of the hip joint and perform a different variety of procedures here. So up here in the top right, we've got a little labral tear here, which it has been repaired arthroscopically. Very nice repair here. Labrum is back up out of the joint with a nice secure repair of the labrum there. Down here below is actually kind of a run through of a arthroscopic tendon repair on the outside of the hip, which I'll get to in a little bit. But not just inside the hip joint with hip arthroscopy, that we can actually go outside the hip joint and do what we call an endoscopic procedure, meaning just with the camera outside the joint and perform a tendon repair there. So a very common problem is hip arthritis. And I see people every day who come in and are surprised to have found out that they do in fact have hip arthritis. This used to be one of the most debilitating conditions in the US and across the world before the advent of joint replacement. That if you look at, there's a certain metric where you can evaluate the best surgeries created since the beginning of time. And number one is hip replacement. Number two is cataract removal. Number three is knee replacement. And what that means is like returning people to the workforce, the billions of dollars saved from people no longer being critically disabled from arthritis. So arthritis is loss of that smooth cartilage that is the bearing surface of the joint. And then as that occurs, we see a lot of extra bone forming around the joint, degeneration of the bone of the joint. And this is a classic wear and tear type injury, or maybe there was a remote trauma that kind of set the joint up to have increased advanced wear. Generally, this is kind of focal, global, a global pain, typically in the groin, but maybe all the way around the hip. Range of motion loss is very common. Notice increasing stiffness about the hip. Mechanical symptoms may notice some grinding, some crunching within the hip. And perhaps there may be some predisposition due to malalignment of the lower extremity. The sister of arthritis is a focal cartilage lesion, and that's something that I treat arthroscopically. These we generally come across when we are scoping for a different condition, or we knew that there was a cartilage lesion present within the hip that is specifically a very small little pothole, not diffuse wear across the joint. So with these, we treat this with a microfracture by actually cleaning up the base of that cartilage lesion and then stimulating the bone underneath with very small little poke holes to create a large clot that then reorganizes into cartilage in that void there. It's a scar tissue type of cartilage. For most people, though, with a big cartilage problem, it is kind of frank arthritis, And then we talk about a joint replacement, which is the typical open surgery seen below, where we actually remove the arthritic femoral head, resurface the socket, and place a metal cup in there and a plastic liner between the two to give a nice, shiny, smooth new joint there that is free from arthritis. Tendon injuries and bursitis. So trochanteric bursitis is extremely common. I see several people a day who come in with trochanteric bursitis. So this is lateral sided pain over the side of the hip. May wake you up from sleep at night when you roll over the hip. May have some pain when you are abducting or bringing the leg away from the body. The initial treatment for this is always non-operative and is generally extremely responsive to non-operative treatment. This can be a wear and tear type issue. Sometimes there's just a sudden onset from a fall where the bursa has become inflamed. The hallmark of this really is tenderness over that lateral hip bone out there. Altered gait's not uncommon because of kind of compensatory different patterns and muscle firing. Steroid treatment is an excellent adjunct treatment to physical therapy, and physical therapy is really the crux of treatment for this. Getting that IT band as loose as possible. My wife calls it my T band. That IT band can be tight over the lateral side of the hip and cause a lot of friction over that bursa. That's also actually what's called external snapping hip, where the IT band is flipping over that bone there. So with the steroid injection, we place steroid within that trochanteric bursa, and that really facilitates somebody's ability to make progress with physical therapy, working on strengthening of the gluteus medius and muscles and the other muscles within that complex, working on stretching that IT band, and then as always with anything hip, really working on core strength because that dramatically improves hip function. Very rarely do I have to do surgery for a hip bursitis, but I would say it's 5 people out of 100 that we can do this arthroscopically, again, going in there with the scope and camera. But most people who are having a bursectomy are actually going to be having a tendon repair associated with that. And I'll get to that in 1 second here. So tendon injuries around the hip, there is a complex constellation of tendons all converging around the hip. So anteriorly, the most common bad actors are going to be the hip flexors. And very common to have inflammation within these tendons. I think I heard somebody mentioning that they may have had an injection into a tendon sheath earlier. Wouldn't be surprised if that was a hip flexor because that's a pretty common indication. These are generally very responsive to physical therapy, and one of the common reasons that we will send somebody for initial physical therapy, like even if they have impingement, because this coexists with impingement a lot, that it may actually cause, it may have a great response to PT. The lateral sided pain is normally coming from the iliotibial band, that bursa, or a glute medius issue. The glute medius is underneath your large butt muscle. That butt muscle is the glute maximus, and the glute medius is one of essentially the rotator cuff of the hip that allows for complex positioning of the hip in space. This can have a tear just like the rotator cuff in the shoulder, and I'll get to that here in a second. And then posteriorly, one of the tendons here, which is actually not featured on any of these, is the piriformis. Having a tight piriformis is quite common and may actually cause some nerve symptoms sometimes that are similar to pain coming from the lower back. That there's a very important nerve called the sciatic nerve that passes underneath the piriformis here. And when that piriformis is tight, it can cause spinal type symptoms. Hamstring tendons, this is a common reason that athletes may miss extended time from sport. That a hamstring tendon pull it can be a kind of a recalcitrant, difficult injury to rehab out of. That if there's no big time tear, these are uniformly treated non-operatively, but they can take a bit to heal up from. Hamstring tendon tears are generally something that we recommend an operative repair if there's a full thickness tear. And these generally are diagnosed by pain with use of that particular tendon or muscle, tenderness overlying that tendon or muscle as long as it's actually accessible and palpable, pain with a passive stretch in the opposite direction of that tendon or muscle, and depending on the level of issue there, if it's a full thickness tear, it may have a true gait alteration. So again, for tendonitis, which is inflammation of the tendon, steroid can be helpful, but PT is really the moneymaker when you're treating tendonitis, to get everything to calm down, and work on strengthening, work on prevention, work on the underlying issues that cause the tendonitis to occur. And then when there is a full thickness tear, that's really where I come into play. So gluteus medius tears, this is looking at the hip from the side view. Again, this is like a rotator cuff of the hip. If there is a big full thickness tear, that's something that we treat in an open fashion, which is shown here below. I tried to not pick too graphic of a picture. But the tendon is being mobilized down to where it belongs here on the femur, and then will be repaired with sutures, just like as is featured up here on the top of the top right central corner. The outcomes are very good from these tendon repairs, and they're very satisfying procedures to do, actually. When you have these big open retracted tears, you get a very nice repair there, and patients do awesome. Hamstring tendon tears are very similar, that with a big retracted tear, these are something we pretty much uniformly recommend a repair on. The times when we kind of waffle on that is if the tear has been there for a long time, because that tendon starts to retract down, and we know the outcomes aren't quite the same, but the principles are the same, that we're using something called suture anchors, where we can load high strength sutures into bone and then reattach that tendon to where it belongs. And then we protect it for a little bit, and then have you get started with physical therapy in order to resume strengthening of that tendon. So coming into the office, what to expect. In general, detailed history is always going to be the first building block of the visit. Thorough physical exam follows this, and between these two, we generally, about 95% of the time, have a pretty good idea what is going on. Plain x-rays, we're an orthopedist office, we x-ray everything. That it gives us a lot of insight into actually what's going on, if there is arthritis or if this is something else that's occurring. Then based off these findings, we're able to formulate a plan of treatment, whether further imaging is needed or whether we can go straight into physical therapy, possible bracing, or injections around the hip to help facilitate therapy. That's my big indication for injections, is treating the pain so that you can actually have like a restful sleep and a little bit more of a normal life, but really facilitating participation and improvement with physical therapy, because therapy is really what's going to be the preventative thing that actually causes improvement. That we can inject stuff all day long and make the pain go away for a little bit, but therapy is the most important part of that cocktail when you're doing non-operative management. And then if there is indeed a surgical issue, or if this is something that is not responding to physical therapy and other conservative measures, then we discuss surgery. Thank you guys for your attention. I'll pass it over to Sarah here for a little bit. Let me stop my share.
You have my slides in.
Oh, shoot. Hang on. I forgot to format them. I am very sorry, Sarah. One sec. Gosh.
Sarah, do you think there might be another question or two in here that might be able to answer before we?
Yeah, I was gonna tie some of them into my spiel here.
I'm almost in here. I apologize, guys.
Yeah, Dr. Seiter definitely touched on some similar things that I'll touch on, but as he mentioned, PT is pretty important in the role of hip pain. So I can give the PT perspective on all that.
Okay. Okay, am I sharing right now?
Nope.
We're
Nope.
not.
Okay. Let's see, one sec.
Thanks, everyone. Just bear with us for another moment. We'll get right back into it.
I think someone did ask if hip bursitis was similar to shoulder bursitis, and that's a definite yes. They're both, like Dr. Seiter said, the hip's kind of like the rotator cuff of the lower extremity. So those bursitis just act to kind of offload the tendons, help everything move easier. So when things are irritated, they do not move well. Any of these other questions I want to answer?
Okay, sharing now.
I'm not sure. I'm not sure how we got another member in here. I'm going to remove it. Sorry about that.
Successfully sharing now, Sarah?
Yes, you're sharing now. So yeah, my name is Sarah Campbell. I'm a PTA for Avalanche, and I work out of our Silverthorne clinic. So some of you might have seen me there. Go ahead and switch to the next slide. So as I was saying, PTs are pretty darn important in hip pain. And a lot of times we'll see patients before they even go to Dr. Seiter, to the orthopedic office. Physical therapy, a lot of people don't know is a direct access. You don't necessarily need a script to come to PT. You can kind of just come in and ask us your questions, and we can decide if it's appropriate to refer you to an orthopedic or different specialty. If you have commercial insurance, your direct access. If you've got Medicare, Medicaid, or some other federally funded plan, then you will need a script from either your primary care or an ortho. So then you might want to reach out to those caregivers. But other than that, we're a doctorate level profession. So we are trained in special tests to rule in and out those different extra-articular and intra-articular injuries that Dr. Seiter was talking about. So we can kind of get to the base of what might be bothering you. And then if we think that some imaging might be appropriate, or if we want an ortho to see you, we can refer easily to them, but at least get you in, get you started, see if there's some exercises that start taking the pain down. So definitely stop in PT if you're having trouble getting into a doctor right away, because we're usually a little easier to get into. No offense. Go ahead and switch to the next slide. So the similar pictures that you might have seen in Dr. Seiter's slides here. So like I was saying, these are all injuries that we treat here in the PT clinic. So pretty much anything that Dr. Seiter would see, we also see. And then we also kind of can assess which muscles or areas you're tight or stiff in, and give you really specific exercises to loosen up those areas, strengthen specific muscles, kind of get that whole hip working properly. Lots of muscles in the hip, so it can radiate up into the back can radiate down into the hip. Pain in the hip can radiate down to the knee, problems at the knee can radiate up into the hip. So we usually have 40 minutes to an hour to spend with you to kind of figure out all the nitty gritty and really decide where that pain is coming from, and really get the exercises starting so that you can work on those and hopefully reduce some pain. I think someone was asking the best IT band stretches, and there's no really great IT band stretches because the IT band is basically just a piece of connective tissue. The important things to work are the muscles that attach into the IT band. And so those are going to be your glute muscles, your quad muscle attaches into it. So any stretching of the hip, of the quads are all going to affect that IT band. And again, the IT band goes all the way down to the knee. So that can even affect knee pain if you're having tightness in your hip. And then, yeah, I think we've got the extra-articular here. So tendonitis, all those are affected with PT. We can kind of determine which tendon's affected, offload a certain area, work muscles to get you stronger around that irritated tendon, and then slowly get that irritated tendon better as you get stronger as well. And I think I kind of covered the other stuff. Dr. Seiter touched on that piriformis syndrome, also super effective with PT, stretching the hip muscles, getting areas stronger around it. And again, all this stuff, we can look at your individual case and kind of give you specific exercises that will be best for you. Obviously, this is just a general talk because no one patient is the same. So hop onto that next one. And then Dr. Seiter also asked me to kind of touch on a little bit of post-op care following hip scope. He talked about the surgery, and then you're usually in with PT following that. So I kind of gave this little timeline here. And again, I didn't put times on it because everyone's different and it kind of takes people different times to return back to activity based on what he has to do in that scope, whether it's a labrum or a muscle repair. All those kind of protocols differ. And Dr. Seiter always gives us those protocols so that we kind of know where he wants you to be at certain timelines. But in general, we're kind of trained to progress you as your motion improves, as your strength improves, to get you back to all those good activities that we have up here in the mountains. So just a quick little post-op plug there. But yeah, check in with us anytime to get a look at that hip pain, because yeah, we can differential diagnose just as well as Dr. Seiter and the guys at VSO can. So yeah, thanks for having me chat for a little bit, Dr. Seiter. I think you're muted still.
Of course. How about a little Q&A here, guys? It's my favorite part of these webinars because I think you can get a little more personalized. I'm having a little trouble dropping down the QA here, Rachel. Maybe, oh, there we go. Okay. So I see Lois has asked, how can you tell if lower back and spine might be causing my hip pain? And Sarah, we haven't already touched on Lois's question here, have we?
I think I did before you were hopping on, and okay. I think we touched on it in the presentation too, just how like some special tests, and either of us could examine whether it's coming from the back or the hip.
Yeah, that, generally an exam in the office is going to tell us the best. Alarm symptoms are things like, oh my gosh, I don't have bowel control anymore. I don't have bladder control anymore. Like those things are indicators that there's severe spine compression going on. But in general, it's something that we kind of gently tease out either in the therapist's office or in our office over here, right across the waiting room. And then let's see, I guess just so I'm not being redundant here, Sarah, we already touched, is there a connection between hip pain and psoas muscle pain?
I don't think I specifically touched on that.
Okay, and absolutely there is. That psoas muscle pain is probably one of the first things that we're trying to kind of eliminate if you're coming in for hip pain. That, there is a lot of different tissue around the hip, right? It's the deepest joint in the body. And in general, if there is some alteration in gait, some underlying biomechanical issue, the psoas becomes unhappy pretty rapidly, and getting that to calm down is one of the things that we're first trying to address, and then really elucidating, okay, is there still an underlying hip issue that we need to treat? But yes, hip pain and psoas pain are interrelated, and in some ways are synonymous, right? The psoas pain is hip pain, essentially, but underlying hip issues frequently manifest with a lot of pain in the psoas. And the psoas is one of the hip flexors for anybody who may be unfamiliar. Carla, I see you occasionally have hip pain, and what should you do first? It does wake you up at night when it's problematic. So I think, it's always acceptable to go in and see Sarah first, because most of the time, that's where I'm going to send you with an initial hip presentation. Unless there's something I see on exam or imaging that is like really concerning to me off the bat, that I'm like, oh, do not stop at go, do not collect $200, straight to surgery. But that's pretty rare in the hip, that unless you're showing up in the emergency room and you've broken your hip, normally our first interventions are non-operative. So I think it's very reasonable to head in to see Sarah. I'm always happy to see anybody. The location of the pain is very dependent on, and what provokes the pain, kind of the exam, is going to be very dependent on the treatment. But if it's waking you up at night, not too uncommonly, that's some bursitis, where you're rolling over on that hip. That's one of the most common things I hear in the office. So I wouldn't be surprised off that if that was the case. And I think Sarah got to what's the best stretch for the IT band. She's the expert. So I just diagnose the tightness and I send it over to her. That my stretch is a surgical stretch where I cut a little piece of it out. Anything else you want to add in on about that, Sarah?
Yeah, just to remind, like, it's all in the quads, it's in the hip muscles. So stretching those muscles out are going to be your best bet. Yeah. And then also times tight muscles are weak muscles. So strengthening those glutes and quads too can be beneficial.
And hip impingement is truly pinching between the bones. Unfortunately, I was looking for a hip model before I came into this room, and I don't have one with me, but it is where the bones of the hip there's not enough clearance. So should be able to rotate around within that socket joint without that, either the acetabulum being too formed and there being impingement there, or with there being too large of a bump on the femoral neck, causing kind of a square peg and a round hole phenomenon. And that'll lead to pain from the pinching itself, but also further damage to usually the labrum. Pain is in the front of the hip, not the side. Oh, sorry, I just saw that, Carla. So probably more related to the psoas tendon. Could be related to some arthritis or something going on within the joint. It's hard to know exactly without seeing you, but that something we could tease out pretty quickly and easily in the clinic or in the therapy office. And anonymous, I see aromatase inhibitors used to treat breast cancer. You often have a side effect as joint pain. Does the drug cause permanent damage to the hip, or does it subside if the drugs are continued? So yes and no. That the joint pain may not be permanent. A lot of the systemic medications that we take, chemotherapeutics included, and high dose steroids, may cause irreversible joint damage. It is certainly, like if you are treating breast cancer, if you are on a high dose steroid for another condition, that's an unfortunate side effect, but you want to treat the really pressing issue, right? That a common joke in orthopedics is that we're saving limbs, not saving lives, right? So yes, there is a chance it may cause permanent damage, but there's also a chance that some of this damage is temporary. I know that's a very nebulous answer. And I'm really waffling there, but it's a more complex problem than exactly that. And it's specific to specific medications, et cetera. Pat, I do go to Frisco. I'm in Frisco clinic 3 days a week on Wednesday, Thursday, and Friday morning. So I'm happy to see you or anybody here at any time. Over in Eagle County at the beginning of the week. Linda, can severe hip arthritis cause pain in the shin, calf, and foot? Yeah, you could have radiating hip pain. Shin, calf, and foot, I'd be much more concerned about you having an issue that is existing in the spine. That a hip problem and a spine problem are not mutually exclusive, right? You know, we generally go with the Occam's razor philosophy that there's one underlying cause for the pain that a person is having, but certainly they are not mutually exclusive. Pain that radiates down into the shin, calf, and foot would definitely cause me to want to get an x-ray and do a very thorough spine exam on you to make sure that there's no weakness, there's no sensory changes, no evidence that you're having any nerve compression. Normally, hip pain is going to radiate down to the level of the knee, but not very commonly does it really cross past the knee, although a big disturbance in your biomechanics and your gait could cause some compensatory pain further on down the extremity. Alicia, I see when you cross your right leg, you have sciatic pain going down from your right hip to the lateral side of the upper leg. Is this a tendon issue? Sitting for long periods, car rides, airplane also causes similar pain. That sounds like you probably got a little bursitis there, I think. So when you're crossing your leg, you're adducting the leg, right? You're bringing it across the body. You're tensioning that soft tissue over the top of the hip bone, which is where that bursa lives. Yes, you could be tensioning like the piriformis over your sciatic nerve. So if you were having a lot of numbness and tingling associated with this, other nerve type symptoms, I'd be a little more worried that you're having some nerve compression. But the sitting for long periods, adducting the leg, very classic for a bursa. And you know, any bursal issue, the tendons are interrelated, right? Because the bursa allows for gliding of the tendon, but this sounds like very classic bursitis to me. Christine, I see you're asking about trephination with injection. Yes, there generally our physical therapists are very good at dry needling, which is somewhat of a trephinating type procedure. That myself.
Oh, you froze for a second.
Action of the steroid. My partner, Dr. Nurki, does some prolotherapy, and that is more similar to trephination with injection. That you're trying to induce an inflammatory response in order to induce some healing. That's my non-operative partner, Dr. Nurki, does do a fair amount of this, yes. Whereas I'm normally trying to cool down the inflammation that's present and allow somebody to surpass the issue. That I do some trephination in the operating room, but normally that's to stimulate a little healing on a repair that I'm performing. Lori, I see that you've had x-rays that show no arthritis and workout plus stretch all the time, as well as have had physical therapy, which seem to make the pain worse. When I get to Frisco, Colorado in the summer, my pain goes away, but then comes back when you're in Vegas. Yes, one of those visitors, tourists, but grew up in Frisco. We love you all. Why does the pain disappear there, but come back with a vengeance here? I mean, just stay out of Vegas. Just stay up here the whole time. To be honest, I'm not sure. I would imagine it has something to do with the change in activity level. That that's a tricky question for me, to be honest. And not knowing exactly where the pain is, and like kind of having a little bit of an underlying diagnosis it's hard for me to guess on that, but best answer is probably a change in the activities that you're doing. You know, I don't know if, because I imagine you're, you know, people come up to the high country to be active, right? So it's a little counterintuitive, right? But I don't know if your activity profile is different when you're in Vegas. Like if you're biking up here and then you're jogging when you get to Vegas, and that's maybe irritating your hips, or something else similar as that. But I doubt it has anything to do with like altitude or elevation. People are always kind of curious about that. Yeah, you can have some barometric pressure changes in the joints, but normally that resolves very quickly. Best guess would be activity based. Anonymous, for mild hip pain, can you start with PT and evaluation there, or you recommend coming in for an office evaluation first? I'm always happy to see you in the office, but I think it's super reasonable to start up seeing Sarah. That, you know, she's very qualified to evaluate you, and it likely is going to improve your condition quite a bit. And save you the expense of a doctor's visit, save you the additional inconvenience and time of having to come see me, although I'd love to see you. John, both your brother and you have hip replacements with pain in the outer groin when lifting the leg while seated. What can be done? We are in our 70s. Evaluating the painful total hip arthroplasty is a pretty complex problem. That there are a lot of potential causes for pain after a total hip replacement. A total hip replacement is very successful. I don't want to scare anybody away from having a total hip replacement. Dr. Kafke does a very good job with these. The underlying issues are a wide variety. It could be biologic, it could be a loosening issue, it could be a soft tissue issue. This sounds a little more like a soft tissue issue, likely. I do think some additional physical therapy, coming in to see Sarah, see exactly where the location of pain is and what we could strengthen around that area, probably would help out significantly. That said, some joint replacements are unbelievably perfect, but the average joint replacement is not as perfect as the native joints we had. So there will be some aches and pains associated with the long-standing pathologies that's existed there. And we do a really good job, but we're never as good as the hip you were born with, essentially. Anonymous, what causes numbness on the outer right side of the thigh area? A couple different causes for this. Could be something as simple as wearing your belt too tight. That is called neuralgia paresthetica. There's a nerve that runs across the waistband called the lateral femoral cutaneous nerve. So that could be compression of that nerve. More concerning is compression coming from higher up on that nerve chain, where the nerve roots are in the spine. Anytime anybody has any numbness, unless there's a clear inciting cause, like, oh, I had a hip surgery and the surgeon told me that there was a nerve injury or something like that, I definitely recommend coming in to see our spine partners, because we want to make sure that there's not some nerve compression that is causing an irreversible issue. Can injection into an arthritic hip help delay a replacement? Certainly. It depends what you mean by delay. That in general can be very effective to relieve symptoms. And so in that sense, absolutely can really help a person preserve their native joint for much longer than they otherwise would be able to, just getting symptomatic treatment. It does not change anything within the mechanical environment of the joint. So it does not delay the progression of arthritis. It just delays the severity of the symptoms, right? And the indications for having a joint replacement are pain and loss of function. So if you can restore function and eliminate pain via an injection and physical therapy to optimize the function of the joint and your overall satisfaction with your quality of life, then absolutely you can help delay a hip replacement, but it doesn't change the arthritic progression. Marcy, I see a couple of months ago you developed hip pain in your right hip. X-ray showed moderate arthritis on the left hip, mild arthritis on the right hip. You started physical therapy right away, which has been helping quite a bit. Good. I always love to hear that. Last Saturday, your hip pain increased considerably, along with new pain in the lower leg. The sharp pains were felt every time you put weight on your right leg. In addition, every night you were awoken at least once a night in extreme pain. One night, the pain was from a muscle cramp in your left leg that began at the toes and went all the way up the calf. I took a muscle relaxer and eventually fell asleep. Past 2 nights, I started taking the muscle relaxer before I went to sleep and have slept through the night. I have an appointment with PT tomorrow, but I thought I'd ask for your opinion tonight. This could be coming from some of the arthritis in the hips. I think as long as you're not having any big sensory changes, any new weakness, I'm not concerned that this is coming from the spine, but the kind of cramping in the lower extremities, does make me think maybe there's a little something else going on. But I think, going in to see the physical therapist, having them evaluate you, having them work with you, work on some of these recent increases in pain, that I think that is a very reasonable next step. But I'd be a little worried, like, is there possibly something going on from the level of spine? Although nothing that jumps out at me that says specifically that there is. Lori, I see that the worst pain is near the front of the hip, and when you try to sleep on the other side, it's excruciating. And injections at the doctor's office have done nothing to relieve the pain, and the pain often runs down to the knee as well. Okay. So I'm not sure where they injected you, Lori, but so that sounds somewhat like possibly it's coming from the bursal sac. But because normally we find people rolling over on their sides causes a lot of pain. Maybe the uptick in your pain is caused by extended seating from a plane flight, actually, and pain running down to the knee as well. I think I'd want to see you in person, but that next step I think would be get an MRI of either the hip or the spine, depending on what other associated symptoms there are. Whether this is strictly kind of mechanical type pain that does just come along the course of the IT band, because as Sarah was saying earlier, your IT band is kind of unique, that it's one of the fascial structures that it crosses two joints, so it crosses both the knee and the hip, and that this can run down to the level of the knee. But if it seems a little more like it's coming from the spine, if it's kind of burning type pain, if there's any numbness and tingling, weakness, those things would be an indicator that it's coming from the spine. Mark, I see you've had a lot of pain in your groin area for the last week. I saw a general practitioner a few days ago who were in an x-ray, and it showed moderate to severe arthritis. Should I start directly with PT, or does it make sense to come in and have you examine it? There's nothing wrong with starting up with PT. With hip arthritis, the surgical solution is a hip replacement. But the precedent to that is doing PT and possibly getting an injection. The injection is something my partner, Dr. Nurki, does, and he's very good at these. He does them under ultrasound. I inject a lot of other areas of the body, but because the hip is so deep and because he's so skilled with the ultrasound, I refer to him. I'd start up with PT. I think that sounds great. You can also always use anti-inflammatories as long as you have no kidney issues and no significant other contraindications like bad high blood pressure or gastric ulcers. That anti-inflammatories are excellent for arthritic pain. massage gun and stimulate electric muscle are safe and helpful. Yes, I think those are very helpful adjunctive treatments. Sarah may have a little more insight on those two. Sarah, you guys ever using a massage gun or like a TENS unit?
I mean, we use massage guns occasionally as soft tissue release techniques. So on the glutes, on the quads, but you can easily do those at home too. So not necessarily skilled on our part. But the stim, also if you have a home unit, two different types of stims. So you've got your TENS stim, and that's more of a pain relieving stim. You can kind of set up 4 pads around the space of pain, and that can decrease pain temporarily. It just kind of confuses the nerves for a little while. And then we also in clinic typically use NMES, neuromuscular electrical stim. And we use that more to turn on muscles. So a lot of times post-op, we'll use that neuromuscular stim to try and get muscles refiring. We use that a lot in knee surgeries and whatnot. But both of them, like massage gun, soft tissue technique, loosen muscles, and then stim can be temporary pain relief as well.
Awesome. Love it. I didn't know the difference between those two.
Oh, yeah.
That quad never wants to wake up after knee surgery. Linda, I see you had prednisone for 13 days for arthritis, and it caused snapping of minor tendons and has not gone after 7 weeks. What do you know about prednisone damage? So prednisone can cause some tendinopathy. Normally it will actually cool down inflammations around tendons, but yes, theoretically, can it cause some weakening of tendons and possible tendon ruptures? Yeah, that is not common, although it happens, right? That's one of the things, like anytime I see somebody who spontaneously ruptured their quadricep or their patellar tendon, one of the things I ask is any steroids, whether it's actually like an anabolic steroid or whether it's steroids like prednisone. So I think, to be honest, I don't know if they're kind of coincident, that I think the tendon snapping is generally more of a friction issue. And I would expect more of a degeneration issue from the prednisone with like a spontaneous rupture. Although 13 days of prednisone generally is not going to be a long enough course that it's going to cause a real tendinous issue. But it's not impossible, right? Nothing's impossible. Let's see, who am I missing here? I'm seeing some other pop-ups. Am I in a, there's a chat.
I think there's some questions in the chat that we could move to.
Okay, perfect. And thank you, Carla. I appreciate your that you thought this was helpful. So Christopher, how do you diagnose hip bursitis? MRI, CAT scan, X-ray. So in general, anybody who's coming in to see myself is going to get an X-ray in the clinic, right? We're orthopedists. It's like going in to see the internal medicine doctor and get a little blood work, right? But it is a purely clinical exam diagnosis. That tenderness over that bursa is like the hallmark of bursitis. It can be confirmed with an MRI, and I generally do not jump to an MRI. That we will first say, okay, you got pretty clear bursitis here, you're tender here, your history lines up. We'll start you up with some physical therapy, plus or minus an injection. And then if those things aren't helping, we progress to getting an MRI. The things that we're looking for in an MRI is a tear of the tendons under that bursa, because those are generally the people who are not responding to PT and injections, that, oh, there is a tear here. And that's why we haven't been able to rehab out of this issue. Yes, on the last slide, did I accidentally have knee pain on there? I may or may not have used a last slide from a prior presentation, and I thought I altered it up. But yes, hip pain was that where I said come in and see us if you have hip pain. That is correct. I meant hip pain. Wendy, I think Sarah already addressed this. Yes, bursitis is the same across the body, and it is an inflammation of that sac that allows smooth gliding of tendons. So it's a different manifestation in a different area of the body, but it is very synonymous. And Greg, I think we touched this on this question here. Yes, injections can help delay symptom progression for hip replacement, but will not delay the progression of arthritis itself. May make it less symptomatic and delay the need for a replacement. Adrian, for mild pain, do you recommend going in PT or evaluation first? I would, and I think we touched on this. I think yes, referral to PT is great starting off there. There's, most mild pain, we can kind of avoid imaging. Like if we see you in the office, we're going to get imaging, right? Because we want the most possible information. But starting up with PT is generally the thing that I'm going to do first with you. So I think that is a great first starting block. Okay, Lori. And I think we discussed the pain in vagus. Yeah, I really don't think it's altitude. Okay, David, avascular necrosis treatment. AVN is a difficult problem, right? That AVN is early death of the bone in the joint. That's due to lack of blood supply. Normally there's an underlying cause, although there is what we call idiopathic AVN, meaning no known cause. So the first line of treatment is treat the underlying cause, right? So some people with sickle cell will get AVN, right? Get the sickle cell disease under control. Some people, and I'm not at all saying that this is you, but alcoholics are predisposed to AVN. Get the drinking under control. People who need chronic steroid treatment for other conditions are at a risk for AVN. That's a difficult one because you can't really take them off steroids. They need it for their other conditions. So we do a joint replacement. But in somebody that we can correct the offending factor, or in somebody that we don't know the offending factor, if the joint has not collapsed yet, we can do joint preservation. That's something I do where we drill underneath the femur and fill it with some bone marrow type substitutes in order to induce some healing under there. That said, it's not a super successful procedure. A fair amount of those people go on to need a hip replacement in a while. It's the best thing we have right now for preservation of that joint, but in a collapsed AVN joint, the treatment is a joint replacement and it's very effective for that indication. Christopher, I see Dr. Dorff diagnosed arthritis in your shoulder, and now you're having pain in the right hip joint. A longer walk or lots of stairs will aggravate it, and you'll limp after a while with the change in gait. That does sound like arthritis to me as well. I think, so I do the shoulder replacements within the group, and see a lot of people who are coming to me for their shoulder replacement and have had their knees replaced, their hips replaced. Having arthritis in one joint does not mean that you have arthritis in another joint, but it's certainly, there's a lot of correlation, right? Not necessarily causation, but having arthritis in one joint, yeah, it's probably likely that you may have some arthritis in the other hip joint. And I see ASIS user had a hip replacement 17 years ago, pain in the groin starting 10 days ago, only after bending over. No pain on bending over, only at coming up. Okay, Chris. So, gosh, I don't know what to make of that. Normally when you're coming up, you're actually firing your lumbar musculature, right? That kind of groin pain when you're bending over is you're firing a little more of the hip flexors. I think pain after a total hip replacement is so complex, we'd have to see you. But I'm betting it's just a little tendonitis in the hip flexors, to be honest. So I doubt it's like a serious issue. It's probably something we can rehab out of with you, but it's just a difficult problem to assess. But most likely hip flexor tendonitis. Tammy, how often does a labrum repair need to be repeated? You had one 3 years ago and have growing pain right around the pubic symphysis that you had before first surgery, but now more intense. Have had injuries to that side of skiing. So labral repair is actually pretty successful. Yes, there are people who need revision labral repairs, or there may be something else going on inside the joint, right? That cartilage damage within the joint. We know those people don't do as well after a labral repair because we can't do, we're not as effective at treating cartilage damage. And there may be scar tissue around the joint. But that said, pain around the pubic symphysis is normally like an athletic pubalgia type presentation, where there's a lot of adductor musculature and things that are attaching around that area. So this may be unrelated to the labrum. I think, you know, if you came in to see me, I'd get you started up with some PT. If I saw something really concerning on your exam, I'd go straight to ordering an MRI to see exactly the condition of that labrum. But this may be unrelated to the labrum, and you may be able to rest easy. I think, you know, it's a dealer's choice whether you'd like to go in and try some PT and start up there, or some people are like, I want to know, I've already had surgery here, I want to go to that MRI. I think that's also incredibly reasonable. So up to you, but may not be related to the labrum. We generally regard labral repairs to be over 90% successful. Sandra, you have pain that seems like it goes around the hip, which a couple years ago made you think you had a hip problem. Then you got pains going down the leg, having to get an appointment with a Vail-Summit back doctor before the hip doctor was available. They took x-rays and did PT for about 9 months for sciatic issues, and it went away. Now it's returned with a vengeance, including how it started out with pain seeming like around the top of the thigh and hip. Starting to hurt down the back of the thigh, like I strained something, always needing to stretch. Should I see the back or hip doctor first? I'd start out with the back. This is sounding like pretty classic sciatic pain. It could be from compression from where that piriformis tendon, that back hip muscle, goes over that sciatic nerve, but more commonly this is coming from compression coming from the back, especially if you've had this issue before. Hi, Bonnie. Based on this talk, I think you have trochanteric bursitis. Very common. I wouldn't be surprised. When you get up, you have lower back pain on the left side, and it's then difficult to place weight on the left leg. However, once you're walking, you don't have an issue. You play 3-5 tennis and don't have an issue. But it is difficult to sleep on the left side. You've done PT and have been working on core and stretching the IT bands, icing when sitting, but haven't seen improvement. I used to live in Frisco and love the quality of medical care there. Do you know someone in Tucson I should see, or what else you can do? And you are 73. So I don't know personally anybody in Tucson, but I would recommend seeking out a sports medicine physician or somebody who specializes in hip training. Oh, and I see Dr. Dorff did your rotator cuff surgery. I agree, he is excellent. I think honestly the next step would be a steroid injection into that trochanteric bursa, and it's normally really effective. That it just may cause a nice breakthrough on the plateau with PT and calm everything down, let you sleep at night. But I think any sports medicine physician, a interventionalist as well, like we have one in our group here, Dr. Nurki, who is a non-operative sports medicine trained guy, is going to take care of you very well and make sure that this is exactly what it is, if it is trochanteric bursitis. And if I saw you in clinic and you did have trochanteric bursitis after the story, I'd give you a steroid injection. Okay, guys, any other questions? Thank you guys so much for hopping on tonight, and thank you so much, Sarah.
Thank you.
Always nice chatting. I look forward to the next webinar, and hope you all have a wonderful evening and stay safe out there. Don't get too muddy during mud season here. All right, bye guys.
Thanks so much for joining us, everyone.
Thanks, Rachel.